You don't need to see me. All right, can you guys see my screen? Someone give me a yes.
Yes.
Perfect. Okay. So before I get started listening to the introduction thing, I just want to make a couple comments. First of all, the agenda today is amazing. All right. You're going to hear about the ED boarding issues. Um, and I don't know if any of you read the medical literature, but there was recently a study out of France that looked at patients. They also have a capacity problem in their hospitals. And they looked at elderly patients who were boarding in the ED because there were no beds in the hospital. And that study found for a patient 75 years or older who boards even one night in the ED, they have a 40% increased risk of mortality during their hospital stay. Our ED boarding issue is huge, right? We often think of patients upstairs, oh, let them stay another night. We don't want to get a bad patient satisfaction score, but we're causing harm to those patients in the ED who can't get into a bed that needs it. So I think it's a really important topic. The other one, of course, Medicare Advantage. We know the numbers are growing. I think on the East Coast, Medicare Advantage is quite popular. Um, Lots of things happening in that realm. We certainly all know about the murder of the CEO of United Healthcare, and the tension that occurs in the community. Social media has made things worse. So I think understanding how to deal with the MA plans, how to appeal things, how to work with them is so crucial. So I'm really looking forward to hearing that talk. The other thing I want to mention, just as a totally obscure fact, CMSNE is actually not an acronym. It's what's called an initialism, right? When you pronounce an abbreviation as a word like NASA, 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 that's an acronym. When you spell out the letters, it's called an initialism. That's one of my little quirky things that I learned along the way and like to pass on to people. It's always helpful in meetings when your CEO calls something an acronym and it's actually initialism, you should immediately correct them, right? It's great for your career advancement to correct your CEO in a meeting. Um, the other thing about CMSA membership, I, you know, I always encourage that if I'm in talks, that the executives pay for membership for professional societies and for conferences for their staff. Look at the low price of this membership and think you're going to probably bring back to your hospital today one tip or more that's going to save the hospital tens of thousands of dollars. I mean, where else can they spend $100 and save $10,000 or 20,000 or more, right? It really, go back to your leaders and say, I think you guys should be paying for us to join these organizations so we can learn from our colleagues. And then I would love to attend that conference in April about changing healthcare. Some of you may have noticed that there's a lot of stuff happening in Washington, D.C., some of it about healthcare. Um, who knows what's going to happen in April by then? Um, will we have Medicaid? Will we have ACA plans? It's crazy. We don't know what's going on. Now, I'm from Illinois, Chicago region, so you can probably guess my leanings. In fact, our governor just proclaimed that we're going to change the name of Lake Michigan to Lake Illinois, and Illinois is going to annex Green Bay, Wisconsin, um, as kind of a making fun of what the president is doing with the Gulf of Mexico, et cetera. But anyways, there's going to be a lot of change in healthcare, and we need to be up on everything that's going on so that we can best provide for our patients. All right, with that, I'm going to go into the Medicare update. You know who I am. We have our objectives here. I put them on the slide so you can get your CEUs. Let's start by talking about discharge planning, right? Not a new topic. All of you know about discharge planning. Um, but I like to bring it up because it's kind of one of those sticking points that always comes up with our patients. All right. So I think all of you know that the Medicare and Medicare Advantage patients are given formal appeal rights, right? If they're admitted as an inpatient, they have the formal right to appeal their discharge for whatever reason they want. And I'm sure all of you have experienced patients who appeal that have no good reason to do it, except they want another night or two in the hospital with room service and high-speed internet and cable TV, right? You have to give that important message from Medicare. right? It has to be within 2 calendar days of admission and then within 2 calendar days of the discharge date. I do like to point out that the rule says 2 calendar days. I'll often heard that said as 48 hours. There is a difference, right? So make sure you're aware it's 2 calendar days, right? You may think you missed something because someone said it was 48 hours. Then you take a look and go, oh, no, we're okay because it's 2 calendar days. If you're giving that second copy of the important message on the day of discharge, remember you have to offer the patient 4 hours to decide if they want to appeal, right? But that doesn't mean they have to stay 4 hours, right? Most people are happy to go home. You give them the notice, you tell them, by the way, we are supposed to give you this notice. I'm required to tell you you have 4 hours to review it and decide if you want to appeal, but you're certainly welcome to leave anytime you're ready or once we're ready to discharge you, right? I do like to remind people that, hospitals are not safe places. Now, a 4 hour stay is not going to cause much harm, but um, you're in a hospital setting with lots of sick people, with lots of infections, right? Why not get out as soon as you possibly can? Get back to your own home, right? We often hear these people who ask, can I just have another night in the hospital? And I jokingly like to tell staff that what you should do is go into that patient and say, I know you want to stay another night, but the patient across the hall has a MRSA infection, and the patient that you're sharing the bathroom with has C. diff, and your doctor, she never really washes her hands. So are you sure you want to stay another night? If I was you, I'd want to get out of this place as quick as I can. Again, don't do that, but just realize we're exposing our patients to infections, to risks by letting them stay extra nights when they don't need to be in the hospital. All right, the important message again, lots of hospitals have trouble with that second copy, right? We haven't yet figured out how to read the minds of doctors to know exactly when they plan to discharge a patient. I know Elon Musk is working on his Neuralink brain implant, and maybe one day we will be able to read their minds. But for now, we have to kind of anticipate it, right? So getting that second copy can be difficult. Some hospitals have said, we're just going to give the second copy every Monday, Wednesday, Friday. That way we're always covered. Well, Medicare made it clear that that is not appropriate, right? That is not consistent with patients properly being informed of their rights, right? So if your hospital or you're hearing about someone doing that Monday, Wednesday, Friday thing, tell them to stop. Your surveyors come in and they see that, it's not going to be a pretty picture. All right. You just got to work with the doctors. You have to understand the process. Again, good case management is following the patients, understanding their course, and making anticipations. You're going to be wrong, right? You're going to give it out and they're going to end up staying that third day. That's okay. At least you tried your best. Now, when we talk about discharge appeals, it often comes up, what happens on the QIO side when the patient calls? It's kind of a black box. The patient calls, we get a call for the records, and then we get a call back whether they ruled with us or against us. But Essentia, which used to be called, Essentra, which used to be called Keypro, they changed their name. They posed these questions in a recent newsletter. What are the key factors you're looking for a safe discharge plan? And what if a member needs higher level of care, but there's no movement on finding a discharge plan? So they pose those questions, like kind of cool questions. So their answer for the safe discharge plan was secure a skilled nursing facility bed if applicable. If going home, ensure they can safely return alone. Now, right away, I have a problem with that answer because we don't send patients home alone in many circumstances. So I don't know why they said alone. To me, it should be able to ensure they can safely return home, right? And that would be obviously a key role that we would make sure that they do have the support, that they're able to ambulate, that they have the services they need. Confirm that home health care is arranged, of course, and then DME is ordered and will arrive before discharge. Again, assuming that it's appropriate for the type of DME that's needed. Right? As it notes in the bottom, they said all arrangements must be confirmed and not pending, right? So if you've got a referral out to a home care agency, but you don't have a confirmation, you can't discharge the patient. Common sense, that's what they're going to be looking for. The second question they asked, which I thought was an interesting one, they didn't even answer, right? So they published it in their newsletter, but then didn't provide an answer, right? And the question kind of threw me off too, right? Needs a higher level of care. What the heck does that even mean? Higher level of care compared to the hospital where they already are, right? That suggests that they need to go to a tertiary care center. So, um, I guess my lesson from this one is that when the QIO gives you an answer, they do have some authority, but sometimes question them. What do they mean? Right? Now, if what they really meant, if the patient needs like a nursing home and there's no movement in finding a nursing home, what do you do? Well, under the federal regulations, if your patient requires skilled care in a nursing home, but you can't get a bed accepted, that patient can remain an inpatient, and those days are considered by Medicare to be medically necessary. You'll get that. Um, that's different than the patient who has a nursing home bed but doesn't want to take it, right? Or doesn't need a nursing home but doesn't want to leave, right? So days where the patient's remaining in the hospital awaiting a Part A nursing home bed are considered certified and covered. Again, documenting that's important. Documenting that you're continuing to contact nursing homes to find availability. All right. So here's the regulation. I'll pass over that. You can go back and look at it later on. Choice of post-acute care providers we know is part of the discharge planning rules, right? We must offer choice to all patients, right? The providers we offer choice to are ones that can meet the patient's needs and have capacity for the patient. This has come up before with, does our list of nursing homes have to include every nursing home in the area? And the answer from Medicare was no, right? If they can't provide the specific need, if they don't have wound care, if they don't have dialysis, if they can't take care of trachs, you don't include them on your list. Most importantly, if they don't have open beds, you don't have to include them on the list, right? We know many areas have lovely nursing homes that everybody wants to go to, but if they're full, right? If you put it on the patient's list, they're going to pick that one and say, I'm going to stay here and wait till there's a room at that nursing home. You don't have to do that. You can exclude them from your list if they don't have capacity. The requirement, again, is home care, SNF, LTAC, and IRF to have a true list that you provide to the patient, be it in writing, on an iPad, whatever method you may use to offer that, right? But the regulations do require you to offer choice for everything, right? Hospice, end-stage renal disease, for dialysis centers, for DME, right? We're supposed to be offering choice for all those things too, all right? So how you do all that, is kind of up to you. It's not as formalized as having to present a list. So some of it's going to be really just counting on you to be doing the right thing for the patient. I will bring up something that's come up on I think the Facebook case management group is when physicians demand the patient go to a specific facility and they get upset when you don't send the patient to their facility. Well, if that comes up, your doctor's ordering discharge to a facility, you are still required to offer the patient choice. Now, of course, approach that in the most rational way, which is go to your patient, provide them the list, but explain your doctor prefers this facility and is going to be rounding at that facility, or their partners are. So that would be your doctor's preferred choice. But by law, you have a choice of any facility, right? If the patient chooses another facility, you go back to the doctor and you explain that you're required to do that, right? You may want to warn your physician advisor, your boss, that you may have an upset doctor because they may start getting all, huffy about it, but you've got to fulfill the obligation to the hospital, right? You don't do that, you guys lose your certification. They're going to come back to you. They're not going to come after the doctor for causing the problem. The last point on here, technically, it's the patient's responsibility to find out if the provider's in network, which is a little bit weird, right? So if it's a Medicare Advantage patient, you have to offer choice of all the nursing homes that accept Medicare patients, even if they're not contracted with the MA plan. I don't think that's very patient-centered, but it's what Medicare says, right? Now we're welcome, and we should, I think, tell the patient that, these are the facilities in your plan. If you choose another one, you're going to have to pay for it. Give them that option. But Medicare says technically you could just give them the list and it's up to them to figure it out. Um, I see hospitals, again, give a list, have a patient check a box that I was offered choice, sign a piece of paper. You don't need to do that, right? You can if it's your policy, but the requirement is that you document that the list was presented to the patient. So if you use one of the electronic methods out there, there's several companies that have electronic versions. You could simply write a note that says patient presented with um, Aiden's post-acute choice program. Patient selected this facility, right? If a surveyor comes in, they should be asking you to show us how you generate a list, right? They shouldn't be asking you to show the copy of the list that the actual patient was presented, right? Now, some of these computer programs probably can reproduce what the patient looked at, but they shouldn't be asking you that, right? If they ask you for that, personally, I would challenge them. Show me that that's a requirement, right? Um, they might get a little upset if you start challenging them, and your boss may be upset that you're challenging a surveyor, but I would certainly do it. Bundled payment programs are growing, right? They're continuing to expand, right? We have all kinds of things out there. Remember that a bundled payment program does not take away your obligation to offer choice, right? You still, again, you may have a bundle payment program where you have an arrangement with a nursing home or a home care agency. You must still offer all the other choices. All right. You can indicate who your partners are. You can indicate, again, your physician preferences, but the list must include all options, right? Sort them the way so your choices are on the top. Put a big star next to them, make them bold, but and tell the patient, what the arrangements are and how they're going to receive, more coordinated care, but make sure the list is complete. All right. Discharge planning is really regulated by the conditions of participation, right? The conditions of participation for discharge planning were updated in 2020. We're now in 2025, and they still have not updated their interpretive guidelines. Very frustrating because the interpretive guidelines are what surveyors use when they walk in your door to survey you. So we wait. I keep bugging them to try and get them updated because we want to know what kind of questions they're going to ask. I will point out, you'll see in red that they talk about discharge plan consistent with the patient's goals of care and his or her treatment preferences. If you go through the final rule that came out in 2020, those words, goals of care and treatment preferences, were used 23 times in that rule. They're very focused on making sure that we are actually participating in the patient's goals of care and treatment preferences, that we're asking about it. We're helping them achieve those goals, right? It's the patient's goals of care. It's not the doctor's goals of care. It's the patient's treatment preferences, right? Again, I'm sure many of you have seen patients, and I certainly did it in my work, where you walk by a room and a patient's almost taking their last breath in life, and yet there's chemotherapy hanging, right? Did anybody offer them the option to not receive chemotherapy, to stop their treatment, to go home, be with their family? Is that documented, right? Now, again, doctors, we hope that they're doing that, but our discharge plan really needs to include that. So some of that discussion you should have with the patient is about whether their goals of care and treatment preferences were addressed. And again, go into your notes, and when you document your discharge planning notes, write those words, discussed with patient goals of care and treatment preferences. So when the surveyor comes in, they can check that box. All right, moving on. Many of you, hopefully all of you, have heard about the new form that's coming out on hopefully February 14th. Actually, not hopefully, but anticipated to be February 14th, so a week away. That's the Medicare Change of Status Notice, right? So I'll start by telling you that with the change of administration, there has been a presidential order to put a hold on all regulations that have not yet been implemented, right? This regulation, because it starts February 14th, has theoretically not yet been implemented, but we have heard nothing from CMS to say that it is delayed. So proceed as planned with your planning for this process. But in the next week, we may hear pullback. We'll just have to wait and see. All right. So what is this thing all about? Many of you who have been around as long as I have remember the era of the rack audits of short stays before the 2 midnight rule, right? And what was happening back then is that the hospitals were getting tons of rack audits for 2 day, 3 day stays. They were getting denied. They were having to fight them. They were losing their fight. So as a result, hospitals took the practice of when doctors admitted people as inpatient, but they thought it might not, it might be denied, they changed it back to observation and just took the observation payment. Right. Now, interestingly, observation payments back then were actually pretty decent because it wasn't a bundled payment the way it is now. It was fee per service. So the payment wasn't that bad, right? The problem, of course, was those patients couldn't get to a nursing home under Part A because they never had a 3 day inpatient stay, right? They went to the nursing home, they had to pay for it, right? Or they got a big bill from the hospital for their observation stay. Patients were mad. What do you do in America when you're upset about something? You file a lawsuit. So a lawsuit was filed on this issue and it started going through courts. It went through courts from early 2000s until last year when we finally got a judgment from a court that said hospitals had to implement a process for patients to appeal their change in status so that they wouldn't be stuck with these big bills. So the regulation is CMS 4204F, if you hear about it, right? Its formal name is Appeal Rights for Certain Changes in Patient Status. Right? So what is this rule all about? Well, the rule is Medicare fee-for-service only, right? Unlike things like the important message and discharge appeals, this does not affect Medicare Advantage, right? It's only for patients who were admitted as an inpatient and then had a change to outpatient via condition code 44, had observation services ordered, not only ordered, but also received. So we're going to talk a little bit about that in a bit, right? Then it breaks it down to only Part B, or excuse me, patients who have no Part B coverage. Right? So in other words, if they get changed to outpatient without Part B, they have to pay the whole bill, right? Or patients who get changed and then stay 3 more days in the hospital, right? Because in that case, if they stayed 3 more days, maybe they should have been inpatient and they should have gotten their right to get their SNF stay paid. So those are the classifications, right? Medicare, when they did their numbers, they said we don't expect any hospital to require giving out more than 10 of these a year. I don't know where they got that number. Whatever the number is, 2 or 200, we still have to prepare. You still have to have policies in place. So we have to be ready. So the other part of this rule that is not a worry for case management, but I like to bring it up, is that patients in the past who were in that situation, right, had their status changed and then got a bill from the hospital or had to pay for the nursing home. They now have the appeal process. They can go back from their 2012 stay and appeal that they had to pay and get their money back. Right. So this is a whole process with a contractor. Your HAIM department may end up calling you and say, what the heck is this? I got a notice to get us records from 2012 to this contractor. We're supposed to look for those records, right? If you have the records still, send it to the contractor. If you don't, send them a note that says we no longer have records for that admission, right? The contractors will figure it all out, and then there'll be a process where the hospital or the nursing home will be told to refund the patient their money, right? So whatever they paid in 2012, you'll have to pay back, or the nursing home will have to pay back. And then there'll be an optional process for the hospital or the nursing home to rebill as inpatient for that stay. Right? Now, this is the one I'm really anxious to see what Medicare says, because imagine them telling your hospital, You had Mrs. Smith in the hospital in 2012. You admit her as an inpatient, change her to OBS. Um, you can now go back and bill for inpatient admission. How the heck do you do that? Right? Back in 2012, we used, I think, ICD-9 still. All right. So different codes, right? CPT codes were different. The diseases, what was sepsis in 2012 compared to sepsis today? It's totally different. Nursing home payment structure was different in 2012 than it is today. So it'll be really interesting to see how Medicare solves this and how they figure out the billing side of it. Right? Will the hospital get paid the 2012 DRG rate for pneumonia, or will they get paid the 2025 rate? Very interesting to watch. Right? I'm sure Medicare is not very happy about having to go through all this. All right, so back to the stuff that you need to worry about. Remember, two groups, A and not B, admitted as an inpatient, changed to outpatient, observation, ordered, and received. Right? Second group, A, with or without B, so anybody, changed with code 44, observation services received, stays 3 or more days, starting with the inpatient order. Right? Now, that may happen occasionally. Right? We get those patients, we change them because they didn't need to be inpatient, but then they end up staying because we have discharge delays. Right? So B may happen, or number two, more often than we think. All right, so what do you need to know? Right? If you're out there having involved in this, you need to figure out how you can tell if a patient has Part A and not Part B. Right? There are estimated to be only 7% of Medicare patients who have A and not B. But if they come in your hospital, you need to know which ones they are. So if you do change their status, you can present them this notice. Right? So is your face sheet accurate? Right? Did they capture the right payment? The patient has A and not B, and can you tell? So figure that out. Second tip, and really importantly, is for code 44 changes from inpatient to outpatient. Right? Remember, not all of these patients require observation services. Right? Patient gets admitted as an inpatient with chest pain. The next day you do a code 44 change, but their stress test has already come back negative and the doctor's ready to discharge them. We're going to change their status to outpatient, but they don't need observation anymore. They're ready to be discharged. And if they're ready to be discharged and they don't need observation, they don't get this notice because one of the requirements is to receive observation services. Right? So you may want to look, if you're doing code 44s, are we changing everybody to observation? Are we providing observation services to some and not others? Because there's a difference, right? And if you don't provide observation services, you don't have to give them the notice, right? Now, it's the rule, right? I'm not manipulating the rule to try and avoid giving this notice. The court set the rule, Medicare is implementing it. So if they don't get observation, it's not like you're cheating, right? Now, what might be considered interesting is if the regulation requires it only to happen with code 44, should we just stop doing code 44 changes? Right? We can self-deny admissions, right? Instead of code 44s, leave it till after discharge and just self-deny. That's allowed. So should we do it? Well, that's something to consider. I got to peek ahead for a second. No, okay. We got to consider that, right? Because a self-denial versus condition code 44 may delay your payment a little bit and may take a little bit more work on the back end, but you don't have to rush around it while the patient's still in the hospital and find your UR doc and find the attending and get a new order and everything. So it's worth discussing whether you could stop doing code 44s to not have to do any of these appeal processes. Right? As I mentioned, by the way, observation is a specific service for patients who need hospital care but are not admitted as an inpatient. Right? On the bottom here is the definition from Medicare. Well-defined set of specific clinically appropriate services. Right? The patient who's staying overnight because they couldn't get a ride home or they want to watch the football game, right? Or their family's out of town. They don't require hospital care, right? That's not clinically appropriate to keep them in the hospital. We're doing it because it's ethically appropriate, That's not observation care. That's custodial care, right? Call it outpatient in a bed, right? But again, we can differentiate between those patients and not order observation services if they don't need ongoing hospital care, right? In your hospital, what do you do with these patients, right? Putting aside even this rule, if you have we often hear the term, it's not very nice, granny dump, where the family can't take care of the grandma. She's getting demented. She's more incontinent. They just bring her to the hospital and they leave her with you, right? You do an evaluation in the ED, you realize there's nothing medical going wrong on, but you can't get the family to come back and pick her up, right? You're going to put her in the hospital. Hopefully, we're going to learn in the next talk how you can avoid putting her in the hospital, but you're going to hospitalize her because you can't just put her in an Uber and send her home, right? But you're going to put her in the hospital to receive custodial care, not observation care, not inpatient care. And if you're putting her in custodial care, we shouldn't be billing observation. We should actually be billing for custodial care. And you can use the code as you see here, A9270, and you can bill per hour. Put it on your claim form so you record these convenience care hours that you're being provided, or that you're providing to the patient. All right. Remember also, if the patient's competent, they don't want to go home, they're in observation, and they want to stay till tomorrow, but their care is done, you have the option to give an advance beneficiary notice. You can say, you know what, your care is done here. If you want to stay, we charge custodial care and we charge $150 an hour. Here's a form, sign it. We'll be glad to let you stay and watch the football game, right? But we're going to ask you for a credit card imprint so that we can charge charge you for the care because your insurance isn't going to pay for it and we're not going to get paid, right? So again, if you have an issue with convenience care, talk to your billing staff about setting this up as a code and develop a process to record those hours. If your hospital tracks observation hours as one of your key performance indicators, and your observation hour number is crazy high because you have lots of these custodial patients, this is how you fix it, right? You stop counting observation hours when their care is done. You switch them to custodial care hours. Your obs hours now truly reflect the necessary care the patient received, right? So the new notice, Medicare change of status notice, it's online. You can find it there, right? As with all notices, make sure you follow the rules. You don't alter the form. You keep it 2 pages. You got to get the patient to sign it and date it, right? If they refuse, again, like always, you have a witness. You document that you explained it. And then you write on the form, patient refused to sign, and you still leave them a copy, right? You do have to really explain the form to the patient, right? There's a requirement in the law that you explain it. But Medicare expects you to explain any form that you provide to a patient to sign, right? So make sure someone who's handing it to the patient understands what it's about. There are boxes to check, so you have to check one of the 2 choices as to what status, which one they're going to be. The no Part B, you check box 2. If they're the stays 3 days, you check box 1. I do want to mention payment, right? Because it comes up with these status changes about payment. People often ask to be admitted as an inpatient because they think it's cheaper for them, right? That's a fallacy, right? That inpatient admission is less expensive, right? We have a Part A deductible. We have a Part B deductible, right? So patients are responsible for their deductibles. Many patients have Part A and Part B. They don't have a supplement, and they're responsible for their deductibles themselves. They can't pass it off to AARP or Blue Cross or whomever, right? So if a patient's admitted on January 1st as an inpatient, they owe out of their pocket $1,676. If we put them in observation, they owe their Part B deductible plus 20% of the OBS payment. So they're going to pay $735. So that patient asking to be admitted as an inpatient is asking to pay more money. Now, if they're trying to get into a nursing home, get that Part A coverage, well, that's a different discussion, right? We have to tell them we can't admit you as an inpatient simply to get you qualified for a nursing home. That's not allowed. But the money side of it, you should explain you're asking to pay more money, right? Now, the patient who has A but no B, right, doesn't have a supplement, they're going to pay more money if they're an observation because they have to pay the full rate, right? But understand the numbers, right? I put on here, by the way, in case anybody's listening from Maryland, Maryland has a wacky payment structure, right? If you don't live in Maryland or work there, be lucky. They have a single state waiver that has all kinds of bizarre payment plans. So we put them aside. All right. So again, this notice, going back, when do you give the notice? Well, if they don't have Part B, when you do their condition code 44 change to outpatient, if they're getting observation, you should be giving them this notice. Right. The condition code 44 process requires you to give the patient a written notice that their status changed. This form, I think, can actually serve as that because it says you're getting this notice because your hospital changed your status. So it actually kind of replaces one of the forms that we have to give, right? So part A, but no part B. You make a code 44 change, they get observation services, you can just give them the Medicare change of status notice. Now, it may be easier to continue to do whatever you do for code 44s and give them the Medicare change of status notice. You know, sometimes we say, let's overwhelm them with paperwork and then we don't have to worry about it because they can't possibly read it all and understand it. But still, you know, do whatever's going to work out best for your hospital procedure-wise. For the second group, right, they have Part A, they have Part B, we change them to OBS, they get some observation services, they stay 3 more days. We have to give the notice, right, on that day 3 or day 4, right? Now, the way we count days on this, it's a little tricky, is think about their appeal. They're appealing their change from inpatient to outpatient. If they win that appeal and the QIO tells us to restore their inpatient order, right? And we restore the inpatient order, will they now have the days necessary to get their nursing home paid? Right? So if we change them, right, on Monday from inpatient to outpatient, they had the inpatient, excuse me, let me back up, clear the slate. They got admitted as an inpatient on Sunday, right? In the ED. No one was there to watch them. The doctor write inpatient order. Tuesday, we see it. We change them to condition code 44, change them back to outpatient. They're still there on Thursday or Wednesday. They're still there on Wednesday, right? And they appeal their change, right? The QIO says, no, we think that admission order on Sunday should be valid again. Well, now we have a patient who is an inpatient on Sunday, Monday, and Tuesday. It's Wednesday, they're appealing. If they win, they get to go to a nursing home if they're eligible, right? They've got the stay. Do they have the condition that requires nursing home care? Great, we do it. So that's a long way to really confuse you and say, count the days for SNF. If they would qualify for a SNF, you got to give them the notice. All right. Like the important message from Medicare, we have to deliver this one if it's the day of discharge within an offer 4 hours. All right. So again, it's offered. They don't have to stay. I like this in the rule. Medicare did say in the second paragraph, hospitals are already adept at timing the issuance of notices. All right. We're already adept. All right. So they have great confidence in hospitals that they've hardwired that second copy of the important message. I don't think that's the reality, but let them think highly of us. So that's kind of nice. All right, moving on. The patient gets this form. They want to appeal. If they want to appeal, the phone number's on the form. They can call the QIO. They can email them. They can fax them. They can mail them. They can do the appeal, right? They don't have to stay in the hospital, by the way, to appeal, right? If they didn't have Part B, right, and they're appealing the change, why would they want to stay in the hospital and potentially incur more cost? Because if they stay and they lose, they're going to have to pay, right, for having stayed those extra 2 days waiting for the appeal, right? So likewise with the SNF, if they're trying to get their SNF eligibility to come back, right, and they win and they're home, they can still go to a nursing home under Part A, even 30 days after their discharge date, right? Now, hopefully, again, we set them home with home care, their family's taking care of them, right? If it's safe for them. right? They can still go home and wait for their appeal and get the decision at home. If they do stay, right, we can give them the advanced beneficiary notice. Again, their status is outpatient. We can say, you want to appeal this? We're going to have you stay because you're going to be receiving custodial care, and we'd like you to sign this form and agree to pay. Right? So that's a process you can look at. All right. So again, ABN, if you want to do that, fill it out appropriately. Um, Interestingly, CMS told us if the patient does appeal and win, we change them back to inpatient. You can't make them pay to stay for those extra days, right? That's just going to be a write-off. That'll be on your inpatient claim and you eat the cost. Okay. The other side of the coin is if they win, we have to make sure if they've gone home that our billing staff gets notified because they have to send in a Part A claim, right? They discharged as outpatient observation. The claim went to the billing staff. They prepared an outpatient claim. Maybe they even sent it in already. Well, now we have to put on the brakes and go back and change that claim to an inpatient claim. So if you do this appeal process and if your patient wins, you're going to have to work with your billing department to make sure they do it right. Okay. What we don't know is what you have to do with your doctors, right? Generally, when you do a code 44 change in the hospital, you should be telling your doctors they've got to change their codes, right? Because when physicians put in their claims, they indicate the type of service, they indicate the place of service, inpatient or outpatient hospital. So if you're changing status, they got to change their claims on the code 44. With these appeals, we don't really know for sure what has to happen. Medicare hasn't addressed it yet. All right. The other question that comes up on the bottom is let's say your patient, you do a code 44 change and the patient appeals it and wins, right? And you look back at the process and you say, no way. This was a basic OBS patient. This never should have been inpatient. We did the right thing, right? You absolutely did the right thing, changing them back to outpatient, right? But the QIO comes back and says, no, we want you to do an inpatient, right? Do you fight for what's right, right? Do you go back and complain to the QIO that they messed up? Do you appeal their overturn? Or do you take the higher DRG payment, right? Because now you're getting $7, $8, $9,000 instead of $2,500. Do you take the money and run? I don't know. It's another one of those ethical things that we have to think about, right? Medicare has not addressed what the hospital appeal process is if we disagree with the QIO. Um, but it's something to think about, right? I probably, because it's not very frequent, I'd probably take the DRG and run, right? The question I do have though is if the QIO rules in your favor, in the hospital, excuse me, in the patient's favor, says it should be inpatient, you take the money, can the RACs in 3 years come back and audit that and take back your money because it wasn't appropriate for inpatient? That would be really bad. So I've asked them that question. Um, because of the blackout in Washington, D.C., they've stopped answering questions. So we don't know. We'll see. All right. So don't start these forms until February 14th on Friday. Maybe delayed. We'll have to wait and see. Make sure you know who has Part A and not Part B. Make sure your Code 44 processes are hardwired, that you're getting observation ordered only when it's necessary. And the best solution to this whole mess is get every patient in the right status every time, right? Any patient being hospitalized in your hospital, have a hardwired process to get the status right. Right? I like to tell hospital executives, and when I talk to HFMA finance groups all the time, I said, listen, if you don't want to staff your case management, your UR teams 7 days a week, I want you to close your emergency department Friday at 5 o'clock, and I want you to reopen the doors Monday at 8 a.m. Because unbeknownst to you, lots of stuff happens on weekends. And if patients are coming in on weekends and there's no one there to get them in the right status, it's going to be a big mess every Monday when they're trying to sort things out. So either put the resources to it or close on weekends. right? Nobody's taken me up on the closing part, but maybe one day somebody will. All right, that was a lot of stuff, and I'm sorry. By the way, there's a lot of writings about that. Again, you heard about rackmonitor.com. I've got articles coming out regularly about that rule if you want to go back and read. Next topic. Inpatient only list changes every year. I'm sure you're aware of that, right? Medicare looks at their surgeries, decides what they're going to change. I could give you a whole lecture about why the inpatient only list is worthless. It's really about money, right? But since the money is pretty important, we have to follow it. Luckily for 2025, the changes were minor, right? You can see the codes that they added to the list. I don't know how many of you have cannulations of liver allografts in your hospital. If you're not a teaching hospital, it probably means nothing to you, right? The bottom 5 are codes for excisions of intra-abdominal tumors. All right, those are open excisions. Most open excision patients stay a long time in the hospital, so they're kind of obvious that they would be inpatient only. The reason they're added to the list now actually is because they're brand new codes. Right? These surgeries used to be billed with a different code. They established new codes, so they had to put it on the list. All right. When I teach the inpatient only list, I just want to clarify, I think it's a list you should never look at, right? It's an Excel workbook or spreadsheet. It lists every inpatient only surgery, right? It's called Addendum E, if you ever see it referred to as that. What you're much better using is Addendum B, right? Addendum B is the inpatient only list plus every surgery that's not on the inpatient only list. In other words, it's every surgery that you could possibly do to a patient, right? And the beauty of Addendum B is you can look and see what's going on, what surgery your doctor's actually doing, right? So imagine a doctor comes up to you and says, I'm going to do a gallbladder removal. Is that an inpatient only surgery? And you look at the list, and let's just imagine looking at the bottom half of this graph, right? Where there's 5 surgeries that have that C on the right-hand side. C means it's inpatient only, right? If you looked at those 5 things from your inpatient only list, you might say, you know what, you're right. Removal of gallbladder is inpatient only. Please write an inpatient order. If you use Addendum B like you have here, you can see that there are many surgeries called cholecystectomy, removal of gallbladder. And you would go back to the doctor and say, Doc, I need to know better what surgery you're actually doing. And the doc says, oh, I'm doing a simple laparoscopic cholecystectomy. I'm going to bill it with CPT 47562. Oh, thank you, doctor. I see that that is on the list. It is not a status indicator C, which means it's not inpatient only. So you should do that surgery as outpatient unless it meets some of the special qualifications to be inpatient. And then you can talk about who becomes inpatient, et cetera, right? So use Addendum B, right? Again, the short descriptors that Medicare has on these lists can be very confusing. So I want to look at the whole list and know what my options are before I go giving doctors the choice, right? If I went into the joint replacement areas, I could see that there's a code for hip replacement that says inpatient only. If I actually go to the description of that code, I can see that that's for a revision hip replacement. So regular hip replacements are not inpatient only, but a revision surgery is. So use Addendum B. All right, moving on. Something you may be hearing about already is a new bundled payment program that's going to be mandatory for 743 hospitals around the country. It's called TEAM, right? That's an acronym. Transforming Episode Accountability Model, right? And what it is a bundled payment program for the surgeries that you see listed there: joint replacement, hip fracture, spinal fusions, CABG, and major bowel procedures. Right? So all of those surgeries are going to be part of this bundle. Anybody having any of those surgeries at one of these mandatory hospitals will be participating. Right? They're giving hospitals a year to prepare. The way this bundle works is a little different than some of our previous bundles because it's going to look at the day of surgery and 30 days after discharge. Previous bundles have looked at 90 days. So with 30 days, I think they're looking to say to hospitals, you have much more control in 30 days, right? 90 days brought in all kinds of incidental things and visits to doctors for their chronic illnesses, etc. 30 days you can control better, right? They're going to look like most bundles at everything that's spent under Part A and Part B, right? Every doctor visit, every lab test, every x-ray, any home care, DME, rehab, anything the patient claim goes in under that patient gets accounted for in this bundle. Medicare is going to set target rates for every hospital, and if you spend less than the target rate for each patient, the hospital will get some of that money back. Right? So the hospital is kind of the initiator, and they get to decide what they're going to do with the money. Right? They get to decide, do they keep it all for themselves or do they work with their doctors, right? Who can have the power of the pen or the power of the keyboard, right? And can decide when they're going to order more tests and who's going to get nursing home and who's going to get inpatient rehab, etc. They can share it with the nursing homes. So when a nursing home admits a patient under Part A for their post-op therapy, their recovery, instead of the nursing home keeping them for the 20 days to get that 100% payment from Medicare, maybe the nursing home will work harder to get the patient home on day 15 or day 10, knowing they're going to share in some of the savings. Right? The DME companies, again, home health care agencies, anybody with spending, the hospitals can make arrangements to share in those savings. Right? We often talk that, it's inducement to try and limit payments and limit services. These are exceptions. We're allowed to make these arrangements. Of course, we're going to want to make sure our doctors and our facilities are doing what's right, right? We don't want them discharging patients who are unstable. We don't want doctors depriving patients of care because it's going to save them money or get them extra money, right? We want to do what's right. But I think we all know, and the data clearly shows that, money motivates things. There's a graph I don't have here, by the way. And I know I planned this, by the way, for an hour, and I think I have an hour and a half. That's why I'm rambling a lot. So if you're wondering why I do this, there's a great graph of nursing home stays. And what it shows is the day of discharge for patients admitted to nursing homes nationally under Part A. And it shows a nice distribution of discharge days, starting at day 12 up to day 30 or 40 or whatever. What's amazing on that graph is that on day 20, there's a huge increase in the number of patients discharged on day 20, right? Why is that? I think some of you may know Medicare pays nursing homes 100% of the fee up to day 20. Day 21 to day 100, it's 80%, and the nursing home has to collect the 20% from either the patient or the supplement. So nursing homes naturally say, God, if we get them out on day 20, we get all the great money and we don't have to work to get the rest, right? It looks bad when graphs look like that. By the way, the same thing happens with graphs of LTACs, long-term acute care hospitals. For LTACs, they have a really bizarre payment structure, but their graph has a peak at what's called the magic day, where the patients transition from a lower paying rate to a higher paying rate. Right? Again, suggesting that LTACs are looking at the financial aspects when they're making their decisions on discharge. It's not a pretty picture. We shouldn't be doing that stuff, right? But it's human nature. All right, back to this program. If you're going to be in it, I mentioned about offering choice. Remember, you still have to offer complete choice. The nice thing, though, is if you're in the bundle and you send the patient to a 3+ star nursing home, you don't need a 3-day inpatient stay. So you can do a joint replacement, send them home or send them to a nursing home the next day, as long as the facility's 3 or more stars. Isn't that great? Right? That helps a lot. All right. So you'll hear lots more about that, by the way, if you're in the program. I'm sure your hospitals will be on top of that stuff. Moving on to social drivers of health, right? We often call that social determinants of health. this is an area where Medicare is now looking to start getting information, right? They want data, right? Thank whomever for finally addressing this, right? Every one of you knows the drastic importance of the social determinants of health in our patients' lives, right? It's huge, right? In fact, when I look at readmission studies, a majority of readmissions are due to social determinants, not health determinants, right? The patient who returns 3 days, excuse me, 3 weeks after their discharge for heart failure with another heart failure exacerbation, most of the time, the reason they came back was because they couldn't afford their medicine. They couldn't afford healthy food, right? They didn't have stable living environment, right? If they had those things, they never would have come back. So capturing these things is so important. We get them coded, we get them captured. The researchers can understand it's not our fault the patient came back. We can't provide safe, healthy, nutritious food to every single patient under our care when they discharge, right? So they're trying to get this data, right? They're going to make it mandatory in 2026, right? Despite this, beyond this program, remember all of these social determinants have Z codes, right? And hopefully some of you are reporting those Z codes on your inpatient claims now so that Medicare already sees some of this data, right? So the measures, you guys are really expert on this more than I. Food insecurity, housing instability, which by the way does not limit it just to people who are unhoused. It includes difficulty paying rent, change of residence, crowded conditions, right? So it's much more broad than just talking about patients with without housing at all, right? Transportation needs, right? The ability to get around, right? Utility difficulties, affording those things. Interpersonal safety, a huge issue, right? Certainly with elder abuse, right? So again, hopefully you have a process in place to collect this data, right? The nice part is if you have a patient who's kind of in your system, they've been seen in the outpatient setting, they've been screened for their determinants, that data is in your system. You don't have to re-ask those questions every single time, right? As you can see, it's aggregate data reporting in this program. So it's not patient specific the way the Z codes are, right? So if patients are worried about answering the questions because they don't want somebody to know that, that they have these issues, especially things like interpersonal safety, you can reassure them that their data is not going to be labeled with their name, their contact information, et cetera. It's aggregate reporting by hospitals, percentage-wise. All right. Um, they've also clarified that if a patient comes into your hospital for a mammogram or an X-ray or a blood test, right, you don't have to do it, right? The screening only is going to be if they come into a hospital outpatient department, a rural emergency hospital, or an ambulatory surgery center. Okay. So, yes, if they're coming into your infusion center to get chemotherapy, they're going to need to be screened, right? If they're coming in your ED, they're going to need to be screened, but not the lab, not the X-ray department, et cetera. So, good news there. All right. DRG changes, CDI changes. Um, I have an allergy to clinical documentation integrity. I get hives when I start talking about some of those things. So I'm not the expert on it, but every year Medicare does make changes, right? I hope you have a CDI team that's keeping your doctors abreast on all that. All right. That they're making sure their documentation is capturing the right terminology that's codable. All right. The DRG changes, you know, really my message to doctors is code completely, right? Document well. Use all the words we used in medical school and the new words that you're being taught. And the payment falls where it does, right? I don't want to be hunting and pecking for certain diagnoses that add a CC or an MCC. That's like gaming the system. Be complete, right? And the reason we need to be complete is it's not just about getting them into the right DRG or the highest paying DRG, right? Or getting their GMLOS that all of you probably track, and you shouldn't be, by the way, getting that right. It's everything else, right? There are a bunch of people out there tracking everything you do. Readmissions, we talked about, mortality, the patient safety indicators, right? All of those use every diagnosis that gets reported, right? And if you just look at the ones that change the DRG and get more money, you're going to miss things that affect mortality, right? Affect your readmission rate. And all of those measures are based on observed versus expected. The expected rate is calculated based on all those diagnoses put into some complicated formula, right? So you don't want someone dying who shouldn't have died, but only because on your codes you forgot to put in there that they had um, type 2 diabetes with renal manifestations or something like that, right? So be complete. The other reason is those external people like US News and Leapfrog and the CMS star ratings that get put out to the public, right? And they get to choose their hospitals based on, what the reviews show, right? I think for some of you in Massachusetts, there's probably lots of hospital choices. Maybe if you're in Maine, the patients don't have a choice. But in the big cities where people go online to decide where they're going to go for their surgery or for their x-ray or whatever it may be, these ratings are important. I don't like them. I have another lecture about why Leapfrog in US News is awful. The main reason, by the way, is that you have to pay to play, right? If you do great on Leapfrog, right? Your hospital has great scores and they tell you you got 5 stars. For you to go out and tell the public you got 5 stars, you have to pay Leapfrog tens of thousands of dollars. Right? Same with US News, right? Health grades, right? I don't think hospitals should have to pay to advertise those things. It really gives me a bad taste, right? I don't like it. By the way, I have another lecture about patient satisfaction. That's another one that drives me crazy. Did I put that in there? No, I didn't. All right. Quick thing on patient satisfaction. Patient satisfaction was studied by a group at UC Davis, and their study showed that highly satisfied patients do use the ED more, but they're admitted more as inpatient, and they have a higher mortality rate because satisfied patients get care they want, but don't necessarily need. Another great study out of Stanford that was published late last year, joint replacement patients, right? Elective, happy patients pick their surgeon, right? They divided all of their joint replacement patients into 2 groups. And it was all blinded. So the hospital, the patients didn't know this was going on. The first half of those patients got their surgery, went home, got therapy, whatever was necessary, and then they got their satisfaction survey, right? The second group of patients got all that same stuff, but once they got home, the hospital sent them a bouquet of flowers with a thank you note signed by the surgeon for thank you for picking Stanford Health System and me to be your surgeon. Those patients who got flowers rated their hospital care significantly higher than the patients who didn't get flowers. Absolutely the same care. And flowers made a difference. If that's not a study that should show that these press gainy things are worthless, nothing is. Right? So, by the way, if you want to send your patients flowers, check with compliance because if they cost more than a certain amount, it's considered an inducement and it's illegal. So be careful. All right, I got to get to going. Okay, new technologies. Every year we have new stuff, right? Hospitals have new stuff all the time. It's great, right? We're making advancements in healthcare, right? This new stuff costs lots of money. And Medicare does have a system to look at all this new stuff and decide if they're going to pay a little bit extra until the payment system can catch up and cover the cost of that new stuff. So I'd like to show the 2025 list, right? These are all the things that Medicare is going to pay extra for in 2025. And you look at the top, there's one that costs $97. No big deal. $250. I don't know what all these things do. I guess a thoracoabdominal branch endoprosthesis, you can tell what that is. But look at the price, $47,000 just for the little tube that goes in the patient's body, right? Now you can think if you're going to do that, you got to pay the company $50,000 for the device. You better get paid reasonably well by Medicare to do that surgery, right? Moving down the list, look towards the bottom, right? The unpronounceable drugs for diseases that are life-threatening, right? Look at the bottom one, Lyfgenia. Um, $2.3 million is the add-on payment. This is a treatment, by the way, for sickle cell disease. It's unbelievable. It cures sickle cell disease. What an amazing advancement, right? But it's going to cost $2.3 million plus per patient, right? So if hospitals want to start doing this because Medicare reviewed the process, they're going to get compensated relatively well for that, at least to cover the cost of the treatment. By the way, the interesting thing about these, and I don't know how many of you know about hospital billing, is we have what's called a charge master. And that charge master is where all of our retail prices are, right? This Lyfgenia, when you put it on your charge master, if you're doing it in your hospital, right, the way charge master prices are set is based on a complicated formula. Most hospitals are going to have to charge over $10 million for this treatment. So imagine you're the patient's family and the patient's in the hospital and gets discharged. They got cured of their sickle cell disease, and you get the bill from the hospital, which usually says in the bottom, this is not a bill, it's just a statement. But you see a line item for $10 million, right? Great for your cardiac program because patients are going to be clutching their chest thinking, oh my God, $10 million. How am I going to pay for that? Um, but it's going to be, it's kind of crazy, right? What about your hospital and new technology, by the way, right? Many hospitals want to bring in all this new stuff, bring in new business, right? Be able to advertise that they do all these cool things. Medicare actually kind of went out and said, we want you to make informed business decisions, right? We're not going to pay you for acquisition costs for capital equipment, like the specialized training and computer systems that are necessary for some of these. The hospitals will pay you per service, but not for the starting fees. So hospitals have to make the right decision about whether they're going to do it or not, right? So for your hospital, you probably have a committee that looks at new stuff and says, should we be doing this? The question I want you to think about as you're doing these things is, should we be doing it? Are we good enough? Are we going to have enough volume to do it? Is it the right thing to do? Right? Or should we leave it to big places who can do lots of it? Right? The learning curve for some of these procedures can be tens or hundreds of patients. And if we're doing 5 or 10 a year, we're not doing our patients any favors. Maybe it makes for a great billboard. Oh, we do robotic this or that. But is it the right thing to do for patients? Right? And I always ask the question, if we're going to start doing this, does the first patient that the doctor does it on, do they know that this doctor's never done this surgery on a human being and they're the first one? It's kind of a question to think about. New technology, by the way, Medicare is changing their colon cancer screening. If you're like me and you have to get colon cancer screening, and now the age has gone down to 45, Medicare is now no longer going to pay for barium enemas. I don't know when the last barium enema was done for colon cancer screening, but luckily they took it off the list. But they're adding CT colonography, right? Which is, some say a little bit better than colonoscopy because you don't have to be put to sleep and have the scope put up you. You still got to do the awful prep. So it's just interesting. They are changing with the times. And then a little bit about screening. If you get a colonoscopy after you do a stool test, like at home, one of these Cologuards, it's considered screening. It's covered 100%, right? But if you have a CT colonography and it shows that you have a polyp, you now need to get a colonoscopy. You still need the colonoscopy. And since you're getting the colonoscopy, now you're going to have to pay coinsurance and deductibles because it's no longer screening. It's considered diagnostic. So for me, I'm still getting colonoscopies, right? CT colonography may show the polyp. I'd rather prep once than prep twice. If any of you have done the prep, you know it's not pleasant. So let's limit it if possible. Quick Medicare Advantage update. God, I keep talking. You guys, I hope I have time.
So,
But go
Dr.
ahead.
Hirsch,
Yeah, do you want me to cut it off? Okay.
well, I think this is important to, present to the group a little bit
Okay.
about the night rule. And then we'll
Okay.
go to questions. There's
Yeah.
actually six that are
Okay.
waiting.
MA plans are following the two midnight rule as of January 1st. They don't think they have to. Yes, they do. Right. I would urge you to work with your physician advisor to make sure they're following the rules, right? The two midnight expectation, the benchmark, the case by case exception, right? They are still allowed to do prior authorizations for surgeries, right? They're not looking at the status, but they want to make sure the patient really needs their knee replaced, right? They're also allowed to look at your two midnight admissions to make sure there weren't delays in care, right? The doctor didn't admit him as a chest pain and then keep him for 4 days just to get the DRG, right? The social admissions, the working up incidental things, right? So if you're going to fight in the MA plans, make sure you have a legitimate case, right? It's not a clock, a calendar, and a crayon. Just because they pass two midnights doesn't mean you make them an inpatient. Review it and make sure it's appropriate, right? Hospitals play games, right? We like to criticize MA. Oroville Hospital, $10 million. They cheated, right? They paid their doctors to make patients inpatients. They had their nurses writing inpatient orders before the patients were even seen. They had doctors put in invalid diagnoses to get higher DRG payments, right? It's easy to criticize MA plans, but there are a lot of hospitals doing bad things. Up your way, Chesapeake Hospital, somewhere up, I don't know. Um, they had a surgeon who is actually now in prison, right? The hospital was just indicted because they were part of the scam, right? They allowed the doctor to do sterilizations without consent, to do hysterectomies without indications. They re-credentialed this doctor despite felony convictions, right? It's horrendous, right? Just terrible. We need to be better. We need to be better, right? If you have trouble with MA plans, do complain, right? Medicare is tracking it. They're hearing from hospitals about the things MA plans are doing. On my website, there's the instructions on how you can file a complaint properly. All right. Last thing is Pepper. If you've been using your Pepper, it's been gone for now almost 2 years. We hope to have it back in spring. Right? They say they got a new contractor. It'll be coming back. It's a great tool to help us with hospitals. Okay. Whew. Questions? Do you want me to read them or what do you want?
Well, I mean, what would be easier for
Okay.
you?
All right. Let me look at the questions.
Okay,
Um,
so I could just start you. So the first one is asking the whole group for information. Would they share a tool on what is called perfect documentation? Maybe I mean, unless you have something,
oh,
we could ask the whole group to answer that.
yeah. Well, guys, put it in the chat for your colleagues. That would be a great session for one of your future conferences. Getting an expert on how do we talk about goals of care, an ethicist talking about those things. Yeah, share, absolutely.
Okay, I just got a message that they couldn't hear me. Can you
Oh,
hear me now?
I can hear you.
I know I
Oops.
can hear me too.
Let me go back, stop
Let's
sharing.
see. Okay, I got a yes. I got a
Okay.
yes.
Yes,
Okay, we're
lots of
good
fun.
then. Okay. So the second question was on one slide, you noted that CMS
Oh,
expects, you got that one?
yeah. Okay. So
Okay,
CMS expects less than 10, not code 44s, but code 44s of patients who don't have Part B or who stay more than 3 days. So less than 10 of those specific patients that would need this notice. Okay. You should be doing, well, you should never be doing a code 44. I hope your processes are all hardwired, but, and I don't know the right number of code 44s. People have asked what's the average? What's the right? I have no idea. That data is not available anywhere.
right. So when they used to have the pros, the pro used to keep track of that and they would notify individual departments. But when we went to the QIOs, we don't get that information.
Yeah.
So just be compliant
Yeah.
is the rule, right?
Yeah. All
Okay.
right. Janelle wants to know when you do a code 44, right? Your obligation by code 44 is to give the patient written notice that their status has changed. The moon is only required if they're going to receive 24 or more observation hours after the change, right? Now, if your hospital policy is to use the moon as your code 44 notice, keep doing it. It's fine, right? as long as you're noting on the moon that their status has changed, right? I don't like that because the moon requires filling out the reason, explaining it, getting a signature, whereas Code 44 notice, you can just give them a typed out piece of paper. And again, if you go on my website on the ronaldhirsch.com on the right side, you can see a sample of a Code 44 notice. All right.
Excellent. So
Um,
Deborah asked, do you have recommendations for billing for custodial care for a patient who was admitted to inpatient? For
yes.
example, you got it? Should they be
Yes.
charged? Yeah.
Okay, Deborah, amazing question. Here's this deal. If a patient's admitted as an inpatient, you cannot change them back to outpatient. They stay inpatient until they die or they discharge. What you should do is when the patient becomes custodial, you can give his hospital issued notice of non-coverage. If you have a safe discharge plan, you can give the HIN 12, right? They should have gotten their IMM, they can appeal. But if you win, you give them the HIN 12, you can charge the patient, and you should inform your billing staff that this patient is custodial, and they'll put on their claim what's called an occurrence span code to indicate that the days were custodial. All right. We would love if there was a way to change a patient from inpatient to outpatient so you could capture some charges, but you can't. Great question.
Yeah.
Lisa asks, how do you find out? If you Google CMS team, I believe on their webpage, if it's still there, they have a map or a listing of the hospitals that are part of the program.
The
Okay.
other thing is if it's not there, the American Hospital Association or the American Hospital Association chapter in your state, they're aware of it too.
They should know. Sure.
So Mary is
Yeah.
asking a good question
Yeah.
for
If the
Medi.
no safe, if without a safe discharge plan, you pay continue reimbursement. Is there an endpoint? No. So For for Medicare, you get your DRG, and then they have a process called an outlier payment calculation. So when I talk about continued payment, what I mean is the days are considered necessary. Your reported charges go into the calculation for your payment. When you have patients who are there for long periods of time, you do get extra money. The extra money covers about 85% of the actual cost of that care. So you get some money, but it's less than it actually costs you to take care of the patient. So you lose, but you lose less than if you got nothing. All right. Um, and the reimbursement is not different if it's social. I mean, so the trick is the patient who needs a skilled nursing facility, you can certify. If the patient's homeless, right, but doesn't need to be in the hospital and you're working to find a homeless shelter for them or set up housing, that's not the same. That's medical necessity. That's not medical necessity for hospital care. I'm probably confusing you. Mary, can you email me and I can explain this better offline because it's a little complicated. Medicare pays if they need a Part A sniff, those are certified days. But if it's a social issue, right? If it's the granny dropped in the ED and they're staying, right? And maybe she did have pneumonia, we kept her for 5 days and now we're keeping her additional 5 days. For those cases, there is not additional money. Okay. We can't certify those days. They're custodial. Okay.
Thank you for that. So there is a question about custodial care in the chat, but I believe that you answered it. It said, do you
Yeah.
ever put them in discharge status if the family is refusing to take them home and the barriers the family to a safe discharge and provide them with IM and a hint?
Yeah. So you do the IMM, the HIN. I would continue in your case management notes to indicate the patient continues to require custodial care, no safe discharge plan, right? The doctor should be indicating that, that they're medically stable. Um, and um, again, your billing staff should indicate those days with that occurrence span code. Yeah.
Okay, great. So only one more question in the Q&A. I'm a DRG paid hospital. If the patient status is inpatient and after UM review determined OBS, then doc discharges the patient at the same day should status be changed to outpatient in a bed and not OBS.
So when you're doing your UM review, I assume you mean you're doing the condition code 44 change, right? And the key is at the time of that change, when that order is written, does the patient require continued hospital care, right? So again, take our chest pain patient. If you do the status change, but the patient hasn't yet gone for their stress test, then observation is indicated because they still need monitoring, right? If their stress test is back and they're in the room waiting to go home and now you do the change, then I would change them to outpatient without observation. So it's a point in time decision as to what to do, right? Every patient's going to be a little bit different.
Very detailed. So I think we have them all, and you're
Yeah.
even 3 minutes,
Oh.
3 minutes
Mm.
ahead. So let me
So you
just
still
check
get
the.
you still get CEUs, right? If 3 minutes, is that would
Oh,
be the
they
boundary?
definitely, yeah, they get
Okay.
90 minutes. So you've been through a marathon of a presentation. Thank you so much. And we called it the Medicare Maze, and it's an under consideration this year, like especially with all the uncertainty. So you've made
Yes.
it really clear. We appreciate you. There's compliments too in the chat for you, and
Thank
many
you.
compliments from us. So you get a lot of clapping hands too.
Thank you. And I'm going to be in the background listening to those other talks because I'm going to learn a ton from you guys.
Oh, that's
Thank you so much for the nice introduction and for the time today. Can you hear me?
Yes.
Great. Let me just share my slides. Can everybody see them?
Yes.
Great. Okay, we'll go ahead and get started. Hospital capacity is definitely a significant concern here in the state of Massachusetts and across the region. Seems like on a daily basis, we are in a code help, a code disaster, significant concerns in all of our healthcare spaces regarding clogging of the system and high capacity concerns in our ED. The objectives today are to focus on the most frequent causes of overcrowding and hospital capacity concerns, discuss ways in which ED case management and ED interdisciplinary team members can make a positive impact towards alleviating some of the hospital capacity concerns, showcase how proactive patient movement like repatriation can help patients progress along the care continuum, and provide strategies for the case management team to assist with patient-specific patient progression along the care continuum. And when we think about hospital capacity and ED overcrowding, I think it's very important to state that it is a system concern. It's not just the emergency department crowding that is a concern. It's not just the operations of the ED. It's a sentinel indicator of health systems functioning. I've done a lot of research regarding hospital capacity and ED constraints, and I just make sure that we acknowledge that we are all a system. And when the emergency departments within acute care hospitals are struggling, everyone should be paying attention. I've done some research regarding this common occurrence regarding hospital capacity. And in 2 studies, Yale researchers described the widespread worsening emergency department boarding and crowding, and it puts patient safety and access to care at risk. When occupancy exceeds 85%, boarding times exceed the 4-hour standard. And under those circumstances, the ED boarding time was 6.58 hours. So it seems like the trigger is when there's capacity concerns over the 85%, is when hospitals begin to struggle, when we see the capacity ballooning above that 85% is when we start to see the backlog. Additional research has put emphasis on the fact that it's not just an emergency department concern. As many of you can relate, there's a lack of comprehensive available primary care in our communities, and that is decreasing over time. We see many primary care clinics at max capacity. We see notices that primary care providers are unable to take on new patients. And what do patients do? They feel the need to see a provider. They go to an urgent care center, or they come directly to the ED. There's limited pathways for chronic care management. I was very fascinated at the previous discussion regarding the TEAMS model. I'm hopeful that some of the innovation regarding the TEAMS pathways and chronic care pathways can provide opportunities for patients to receive care in the ambulatory area rather than arriving in the ED for chronic care management. The ED staffing and deployment of personnel, including the use of equipment in the emergency departments, is something that a lot of healthcare organizations are studying very closely. You will see many organizations, especially across Massachusetts, looking at their ED structure, their ED square footprint, expanding ways on the different methodologies to pull patients through the ED, maybe moving different parts of the ED, segmenting off different parts of the ED for strictly ambulatory flow, outpatient flow, and trying to manage the volume of patients that they have boarding in the ED departments. Some EDs are building on to their brick and mortar structures. Some have temporary tents. Some have different ways that they're managing the extreme ballooning volumes in their emergency departments. It is a growing concern regarding the boarding volumes within the emergency departments. It is not uncommon for patients to stay 3 or 4 days in the emergency departments in an inpatient status, waiting for a bed upstairs on the inpatient units. What we are finding is like this cascade a cascade of events where patients are staying longer in the inpatient stays in the inpatient units as well, because they're unable to discharge to a safe setting. We just talked about this morning how we have a lot of custodial care patients. We have a lot of complex issues that the case managers are trying to resolve to have a safe discharge for the patients on the inpatient settings and also in some of the observation units. So that creates a backlog. Now patients are staying longer on the inpatient or observation unit areas, and the patients in the ED are unable to get to a bed in a perceived amount of time. We have many older patients with a lot of chronic conditions, a lot of complexity. We have a lot of comprehensive interventions that require specialty consults and unique treatments that elongate the patient's length of stay. We have limited staff availability or a limited resource availability, delaying treatment options. And as mentioned, we have an exit block. The need for timely, safe discharge options is becoming few and far between. As many of you can relate, it's extremely challenging to get these patients discharged to a safe setting out in the community when we have numerous community resources that are diminishing or disappearing completely. What we see across Massachusetts is that nursing homes are closing at an alarming rate. And this is extremely, extremely concerning at many levels. Due to the financial pressures that are coming down on a lot of these nursing homes, they are unable to meet their financial bases. Thus, they are closing or limiting staff or diminishing the amount of care areas that they are able to provide. As you can see in these notices, we've had numerous closures across Massachusetts, and it's very concerning. This is being addressed at many forums, including the state. Mass Hospital Association is addressing this across the region. This has become a very hot topic across many of the legislative floors to discuss ways to support our community facilities so that they can stay open, so that they can provide high quality care to our residents across the region, so they do not have to come back to the hospital or receive any other additional medical services due to complications that were not proactively managed in these settings. So this is very concerning to us all. I want to take some time to focus on this visual. This is a wonderful reference that was provided by the Mass Hospital Association. They wrote a white paper called A Clogged System, Keeping Patients Moving During Their Care Journey. And this is a perfect visual to show the complicated space that we all live in at the present time. And it shows how complex and detailed this system is when one piece of this system is broken or if it's slowing down, if it's not resourced appropriately, we all feel the burden of this. So let's just walk through all the elements here. Starting with the left, before the hospital. So this is really our community colleagues and how patients are managed in the community so they do not have to resort to coming to the ED or our urgent care centers. Before the hospital, there are fewer and far between primary care services that offer a wide range of services and are taking on new patients. As mentioned before, we have many PCP offices that are at their max. We have a reduction of primary care providers that are available in the community to take on new patients or the time to see patients day of. So what happens is those patients then arrive in the emergency department. We have many, we have many patients that have delayed care since the COVID pandemic and are now starting to get back into the care system, but they have a lot of chronic conditions that have not been managed and they need comprehensive care. We also have a significant behavioral health crisis, not only in our adult population, but in our adolescent and elderly population. Where are they receiving care? We receive notices regarding the closure and of services out in the community regarding behavioral health and mental health. So when patients are in crisis, they come to the ED. So we have sicker patients, we have older patients, we have patients that are using the ED for unnecessary reasons. If they could have received the care in the ambulatory setting, they would not have had to come to the ED. So thus we have a clogging and high volume of patients coming to outpatient ED settings. Many can receive their care in the ED and be discharged from the ED if they can continue their follow-up care in the ambulatory setting. If not, they come in as observation patients, or if they have complex needs that need emergent hospital care, we admit them. And that stimulates our ED boarding conundrum. While in the hospital setting, we have longer wait times. We have access to care that's quite challenged. We have severe workforce shortages. So it slows down that timetable, slows down the time where patients can receive those specialty consults, slows down the time that the patients can receive that testing, those inpatient interventions. At the same time, we have hospitals and having significant deep financial losses. We are hearing about cuts from the insurers to the hospital setting. We are hearing about increases in workforce costs. Many hospitals have had to use traveler team members to meet the gap of the severe workforce shortage, and that's cost that's additional to the hospital organizations. We've seen an increase in supply charges due to lack of access of supplies. So that is another burden that the hospital organizations need to budget for. So we're seeing a lot of challenges within the hospital setting that have made costs skyrocket that we are trying to manage from our budgets. So once in the hospital, we talked about the longer lengths of stay and the challenges getting patients to the post-acute setting. I think where a lot of the case managers on the call today are really struggling with the inability to discharge patients, those stuck patients. So we'll talk about different ways in which we can manage that. But I think organizations like Case Management Society of America and the forums that we have through this organization, it really helps us work as a team to think creatively about how we manage these patients. It continues to connect us to resources out in the community on how we manage patients and how we can discharge them safely. We're also seeing hospitals providing additional unpaid care to these patients. If insurances are not covering certain elements of the patient's care needs that the patient requires upon discharge, and the patient cannot fund them themselves, often hospitals are providing that care, those funds, that equipment, those services to patients so that the patient can continue to progress along the care journey. So that is also an additional budgetary ask for the hospitals that I know many hospitals are trying to manage. With patients that have absolutely no insurance, that is also a conundrum for the hospitals themselves. Patients may have catastrophic concerns and came in emergently to the emergency department, and they have no coverage for rehab or any type of comprehensive home care or any equipment. But yet the family is saying we cannot care for this patient after this catastrophic injury, and we need to have a creative solution for that issue. So it's quite the challenge right now from a budgetary standpoint, from a goals of care standpoint, from an ethical standpoint. And it's very important that the interdisciplinary team gather together with the patient, with the family, and talk about how we can make a comprehensive care plan to discharge the patient where we're all comfortable. So it's quite an interesting time. In terms of patient flow, I want to also showcase this white paper, and this was completed by the Institute for Healthcare Improvement, or IHI, regarding hospital-wide patient flow. This is actually a second edition of this comprehensive concept, and I left the resource here on the slides, and I think you all will get these slides. But I really encourage you all to look at this document. It's quite lengthy. So I showcased here Appendix B, which has really the visual and the high level Cliff Notes version, so to speak, of the key drivers for achieving hospital-wide patient flow. And I add this here because I think case managers have a very interesting lens to the healthcare system. We're all investigative by nature. We're all curious. We're all intuitive. We see the system in a different way than many other care team members that we work with. And I think it's really imperative that case managers get involved with organizational initiatives regarding improvements. I know time is always a concern, but talk to your colleagues, talk to your leaders about different ways in which you see that we could improve hospital-wide patient flow. And after this session, we can have some conversation about different ways and different ideas we can introduce into the system. So going back to the diagram here, what we want to make sure of is that we're caring for the patient in the right place at the right time, making sure that they get the right care to meet their unique needs. So what we need to do is shape or reduce the demand that's coming into the ED, or match the capacity and the demand, or completely redesign the system. So if we break this apart, how do we shape and reduce demand? We reduce demand by providing end-of-life care in accordance to the patient's wishes. So if a patient is being managed in the ambulatory or in an ambulatory area or in a facility, we need to have conversations with that patient to talk about how they feel they would like to manage the end of their life. Many patients have healthcare proxies. Many patients have documents describing the care that they would like to see when they come to that time, but many don't. And I think we do have an opportunity to have those conversations when we're not in an emergent or hospital setting to understand what the patient's wishes are. So that means that they are not being sent back to the hospital for end-of-life care. I think Dr. Hirsch mentioned that during his conversations this morning to say, have we had these conversations? Is the hospital the right place for the patient? And some patients may want everything done and they want to be hospitalized, and that's their choice, and we have to respect that. But some may not. So getting involved with initiatives in your hospital organization regarding healthcare proxy and end-of-life discussions outside of the hospital setting is really important. The second driver that we can really focus on is preventing avoidable hospital readmissions. And the conversation we had with Dr. Morley 2 weeks ago was phenomenal. I took lots of notes regarding avoiding readmissions. it was mentioned and reviewed there as well regarding the interventions in ambulatory settings by primary care, ambulatory settings, ambulatory case management, ambulatory social work to reduce avoidable hospital readmissions. Both Dr. Morley and Dr. Hirsch talked about social drivers of health that bring patients back to the hospital that we really do need to address. And I encourage case managers, social workers, nurses to get involved with many of the initiatives that are starting to roll out regarding the reduction of social determinants of health that the patients experience. Also, we want to reduce the unnecessary bed days after the patients meet medically ready criteria for discharge. I think that is what case managers really have a deep skill set in what we're trying to do each and every day. We do have many challenges to get those patients discharged in a safe and effective manner. But I think verbalizing the reasons why we are unable to do that quickly, timely, in an effective manner is very important. Many organizations track avoidable days or unnecessary days or non-medically ready days in different forums. You can then begin to categorize those reasons and elevate those reasons to leadership or to these initiative groups to start working on some of the core reasons as to why this is occurring. And there's very valid reasons, some that are in our control and some that are not in our control. Many at this point are not in our control as a frontline case manager. So we need to elevate those reasons and quantify those reasons and create initiatives to start addressing those reasons. So we wanted to decrease ED visits. We've talked about that. We want to decrease the demand for hospital beds by reducing preventable harm. So how I interpret that is when a patient is in a bed, we want to make sure that they are not receiving any interventions that cause them harm. Also, making sure that they do not fall, they do not receive any skin injuries, that they do not receive medications that are not in their formulary. We do not want to create any conditions, hospital-associated conditions that elongate their hospital stay. So that is very important that we focus on that as a clinical system. The last part here is to shape or reduce demand is to really focus on surgical scheduling. If we look at the surgical schedules, whether it's inpatient or ambulatory scheduling of surgeries and procedures in our organizations, we can see that there is variation. I think probably many of you are thinking, oh no, Tuesdays are the worst for orthopedic surgeries, or Thursdays, a super high volume of GI surgeries. There's a natural pattern of scheduling that exists in every organization, and there's reasons why those schedules exist. But if you truly understand the pattern and do some deep dives of the data and trends, you can see that our patient flow is distinctly designed in a way that is either helpful or harmful, especially to surgical units and the flow of those units. So a lot of organizations are taking a deep dive into this space to truly understand if there was any way to level out the surgical scheduling so that those patients that need a bed after a surgical procedure get the bed in the right unit and we don't have peaks and valleys of flow. Many organizations are now looking at 7-day-a-week schedules, not just the classic 5-day-a-week, so that there is less variation day to day. If we look at the match capacity and demand, we're really focusing on data-driven learning systems here, a lot of analytics in this space. I'm sure many of you case managers receive a lot of information from different vendors out in the community regarding different data systems that are available to healthcare organizations that look at the acuity of patients, how long it is anticipated these patients are in the hospital, and different data analytic systems that could help organizations understand their real-time demand and capacity. Larger health systems are developing command centers, and we'll be talking to Greg Martin in a few minutes about different command centers that have been developed that look at the overall demand across larger organizations between their acute care hospitals, their rehabs, their intake of patients from elective surgeries, where patients are going, looking at those flow patterns across a larger organization, across a region, to see if there is any way that we can manage the flow a little bit better. And lastly, and I think this is what we're really all honing in here, is how do we redesign the system? Because right now, our whole system across this region in the Northeast region needs to be redesigned. And every organization is going through many transformations now, but how do we redesign all of the healthcare systems across the Northeast to improve efficiencies, to improve throughput, to improve management in our individual patient care areas so that we can bring patients in a timely way to the right care at the right place at the right time. And again, I think case managers have a unique lens into the system that can really lead some of these conversations and come up with creative ideas as to how we begin to move the dial. So really excited to hear about ideas and thoughts that you all have that we can implement with small tests of change throughout the New England region. So here I'm going to pass it off to my colleague, Greg Martin, who is the program manager for repatriation. Greg?
Hi, everyone. Thank you so much for allowing me to join today and to give a glimpse into a space that I have a very huge passion for. We work in the Patient Transfer and Access Center for the Mass General Brigham system, and we have a team of case managers here, which I feel is a unique and growing space as systems come up with capacity command centers or access centers or transfer centers. A lot of them are traditionally staffed with ICU or ED trained nurses who are taking the incoming calls and triaging the cases, talking to the doctors. But when you bring a nurse case manager into the mix, as Kim had alluded to, we do have a very unique lens into the care of patients, the access of care for patients, progression of care. We understand the clinical status. We know revenue cycle. We understand authorization processes. We understand discharge barriers. And some examples of that is, can we interface with finance? So say if the insurance is out of network, maybe we can get a single case agreement. We can reach out to our resources. Do we have to reach out to our transplant financial coordinators to have, a potential transplant evaluation case reviewed? We can identify, discharge barriers prior to the patient arriving to the system. And then we can make sure that when they're in the system, that they're progressing through the system and they're progressing their care. I think a huge part of having case managers in your transfer or access center is really similar to discharge planning case managers on the call, while you learn your post-acute options, your LTACs, your IRFs, your SNFs, we're kind of learning all our equivalents across the region. What are the other systems, the other academic medical centers, the other hospitals, the other community sites across the region, and what specialty services are provided by those health systems, and also what insurance networks are available in your region, and utilizing that understanding when we get farther into this slide and we talk about some screening practices, that really comes into play from alleviating capacity when it comes to transfers, because as we all know as case managers, any point of care transition is it's important from a patient safety standpoint, from a continuity of care standpoint, and also from a capacity standpoint. So one very unique thing that we utilize is we have our enterprise asset management colleagues. We have, a bunch of Tableau dashboards. We have transfer huddles in the morning. We have system huddles. So we utilize real-time system service capacity analytics to really direct patients to the most appropriate pathway to access the care that they need, whether that be one of our academic medical centers, one of our community hospitals. Maybe we can review the case, do a deep dive, and say, you know what, this patient from a functional mobility standpoint, they're functional, they're active, they're stable. The doctor who accepted the patient thinks they could go to outpatient. Let's get them an urgent outpatient visit in maybe the burn clinic or neuro clinic. We can evaluate patients with the doctors for potential round trips or leave of absence, where we take a patient into our system to receive an outpatient procedure, such as an ERCP. Maybe they're going to EP or cardiac cath, provide a service to the patient, provide the care they need, and then they return to the hospital that sent them to us. And then another interesting, as I report to Kim Barry and the care continuum management across the system, having a case manager at the forefront of when a patient is accessing your system, you can interface and identify cases that you may need to send to other people across your system. Maybe we need to alert complex case management in the system at the local level. This patient's coming in. These are the barriers that we see. We're going to follow them for potential repatriation. But if we're unsuccessful, this may be a patient that you could, that may need some additional support to get them through the care continuum. Maybe we can loop in our leased bed colleagues to see if maybe this patient would qualify for some leased beds that our system utilizes. We can interface with post-acute leadership from the admitting side, the discharge side, see, identify something in our system that this patient may need along the continuum. And then we can also utilize local hospital case management leadership as needed when cases are coming in. Next slide, please. And so what we do is we screen all inpatient to inpatient transfers into our system, and this excludes life or limb and emergent. So obviously, we want to provide the life-saving treatment for patients that need it, that they can't receive the care at the hospital that they're currently at. And when we screen these incoming patients, we really focus on, first and foremost, what is the clinical need, the acuity, and the priority. Is this ICU? Is this a life or limb? Is this patient, do they need to get here immediately? What's the triage? Can we wait a day? Are they normal priority? Are they urgent? We take into account system capacity and resources available. If we have our huddle in the morning where we have a multidisciplinary approach, we have our access nurses, we have the case managers, we have our capacity MD, we have our medical officer of the day, we have our nursing supervisors from our local sites, we have administration from both sites, we have everyone available in that huddle to truly make sure that we are protecting our system from a capacity standpoint, which ties into our ED. If we have a transfer request and our ED, our academic medical center, has 240 patients and 90 of those are waiting for beds, that's a day that we're going to have to make very, different decisions than a day if we're in normal operations and we have a lot of resources available. Maybe we can interface with the RN supervisor. Hey, do you have any ICU beds? No, we're 8 over today. Okay, well, we're not going to be able to take this patient. So let's see, are they known anywhere else? Are they followed anywhere else? Maybe they've already had 2 other cardiac surgeries at another hospital. Why do we have to now bring them to a new hospital? We take into account patient preference. Also, as I just mentioned, continuity of care. Maybe they're already listed on a transplant at another center and the referring community hospital just doesn't know because it's an emergency, the patient's sick, they can't care for them, and they're just calling higher level of care options blindly. Sometimes no one is really actually looking into the continuity of care. And then on top of that, Many people are not looking into the insurance network status, which I know is a very complicated landscape. But we really try to approach this from a patient-centered approach where, like I said, if maybe a patient is already listed for transplant in another center and the insurance is out of network of this, why are we going to, bring a patient to us that was accepted by a physician? Me and my team can interface with that accepting physician and say, hey, we looked into this case. They're actually followed with X, Y, or Z for liver. They're listed there. This patient's insurance is out of network with us. It's really in the patient's best, interest to go where they're known to for continuity of care from a safety standpoint and from a resource standpoint. Maybe your insurance is out of network. Maybe you're at an outside hospital where, yes, you need services that can't be provided where you are, but you do need higher level of care and you're stable. If you have an insurance that's out of network with us and you have a 40% out-of-pocket cost, that's not patient-centered care, bringing them in and subjecting them to 40% out-of-pocket expenses. And many patients and providers don't even know that some of those aspects of insurances exist. So we really try to look at it and be a steward to the patient and the system at the same time, where if a patient can access 5 academic medical centers in Boston and can't come to us, again, there's no reason for that patient to come to us. We really try to approach this from, can this patient receive care in the network that their insurance is in network with? Maybe they need transplant that's not available there. That's something that we would, work to bring them in. Maybe we have to get an out-of-network prior authorization. Maybe we have to get a single case agreement. And then our screening is actually an opportunity as well, where we try to identify cases that are very well known to outside systems and that are really just coming to us for something specialized. Maybe it's another academic medical center that doesn't perform the specific heart surgery the patient needs, or maybe the patient is 3 states away, lives 6 hours away, and it just needs, 1 or 2 consults and a procedure that can't be done where they are locally. So we really try to identify these patients. And what we do is we'll send agreement letters to the referring hospital, where 1 letter goes to the referring provider, 1 letter goes to the patient and the family. And it really sets the stage for the patient and family to help them have a mindset of, you live 5 hours away from Boston. You're not going to, go down to Boston, get stuck there, be far from your family, your friends, your local resources, your post-acute resources in your home state. So we're really trying to identify patients that we want to help, systems that we want to help, bring the patient in for the care that they need, for the tertiary quaternary care that we can provide, and then setting up patients to return to those hospitals. We work very closely with all of our internal hospitals as an MGB system, and then we also work with all the outside hospitals across the region. And I'm sure there are many of you on the call that have interfaced with me and my team at some point in regards to this program. We also have an international office here at Mass General Brigham, but we have gotten involved with some non-embassy payer cases. So we've done both local and international repatriations. And we can also be a lens to, utilizing certain pathways, and one that relates directly to the topic at hand of ED boarding capacity is maybe we can actually, if a patient presents to one of our academic medical centers, they're in the ED, there's 240 total patients, 90 boarders, and their care could be safely provided by one of our specialists at one of our community hospitals. We have pathways where we can talk to the patient, sign all the paperwork and forms, get consent, and get the patient accepted to one of our community hospitals so they don't have to wait. That helps, as we said earlier in this call, that your mortality can increase up to 40% depending on how long you stay boarding in an ED. So if we can get that patient out of the ED, not only from a satisfaction standpoint, no one wants to sit on a thin stretcher in the ED around people screaming and yelling and chaos. We've all seen it ourselves. We see it on TV. It's very prevalent. So if we can get a patient out of the ED into one of our community pathways and get them the care they need at our community hospital and get them out of the ED faster, that it's a win-win for everyone, both from a capacity lens and a patient care standpoint. Next slide.
Thank you, Greg, so
Thank
much.
you.
I really appreciate your time and all of your efforts. Greg and his team are absolutely phenomenal with the amount of research that they do for each and every patient to make sure that we are meeting the individual patient needs where they are and getting them the access that they need at the time. And it really speaks to the lens of a case manager And what I've mentioned before is the unique lens to see across a system of care and really help advocate for the patient to get the right care at the right time in the right place. I'm a strong advocate of requiring case management at every point of entry in a hospital. So we have PTAC case management. We have case management in our PACU areas and also in the ED. So we are going to continue our conversation this morning specifically regarding the ED. And I know across many organizations, there are different role types. There are nurse case managers, there are social work case managers, there are clinical social workers, there are care navigators, different role types. And I just wanted to say that it's so important that we all work together as an interdisciplinary team. Each bring their own expertise, each bring their own viewpoint of the patient's condition. And we do need to communicate with each other face to face in addition to what's in your EMR. But that face-to-face communication is absolutely vital, especially in a very chaotic ED environment. But in terms of ED case management, I think every ED case manager that I've had the pleasure of working with has been assertive, inquisitive, has been the ultimate networker who has a role in teaching not only the patient and the family, but also providers, nurses, other disciplines, any other community resource that come into the ED. We play an active role in teaching. And we're very determined, which is really important. So the ED case manager, I truly view them as a gatekeeper. So trying to sort through the minimal amount of information that you have about a patient at that present time to assess, is this hospital the right place for this patient? Different hospitals have different avenues that, that Greg just reviewed. If you're in an acute care, tertiary, quaternary hospital, ED, is this the right place for the patient? Should you stimulate some of that repatriation flow? If you don't have access to that repatriation type process, think through, would this patient benefit from staying inpatient in the hospital? Is it an observation status? Is it an inpatient status? Is this custodial, as what we just reviewed? Is this the right place? So it encouraged the ED case manager to develop a notification system with their internal team to prioritize cases. So ED environment, super chaotic. You have outpatients, you have inpatients, you're boarding patients. Many organizations have developed an internal communication system amongst their interdisciplinary teams. Either something in the EMR or a different way internally to notify from the providers, the staff nurses, the different team members in the ED to notify the case manager that the patient needs their attention. We want to make sure that the assessment tools that are in Epic are asking the right questions and that the documentation that we provide within the EMR is transparent and concise. And it also highlights next steps. Again, chaotic environment, you get pieces of information at different times. We want to make sure that anyone looking in the EMR knows what the plan is. And again, it could be casual conversation in a system that you developed internally. But at the end of the day, it is vital that we keep track of our documentation in the EMR. It's really important that we stay current with the utilization review. As Dr. Hirsch mentioned this morning, using outpatient leveling, using observation leveling, using appropriate inpatient leveling. Many organizations have created observation units. So once a patient is leveled as observation, they physically move to a different location within the ED or within the organization itself. It's vital that we prioritize this process because case management activity in this space begins the revenue cycle process, as Dr. Hirsch reviewed this morning. It's absolutely vital that we get it correct and that we are compliant by being that ambassador to delivering ABNs, to delivering non-coverage letters to patients when they're not meeting criteria. So it's really important that case managers stay current with utilization review. As mentioned, highly supportive of partnering with all of the interdisciplinary team members in the ED, sit in the center of the unit. And a lot of people cringe when I say this and say it's so loud, it's so busy, it's so chaotic. And yes, and yes, and yes, it is. It's an emergency department. But I think it's absolutely vital that as the gatekeeper, that the case manager does sit within the unit and have a space. If that case manager is out for the day, and your covering team member is in the right place, they would know this is where I go to get help. This is where I can get resources I need or begin the process of developing a plan. I've been through walked through a lot of EDs, and one of the first questions I ask is, where does the case manager sit? And they, majority just point and say, over there. Or, oh, I have to talk to the case manager every day. He or she knows the plan. He or she, really manages this unit. It's absolutely important. Again, using your role as a teacher, you're educating the providers, the residents, the medical students, also other team members on what is possible for a patient or other directions we can go with a patient's care plan, or providing the information to help enhance the care plan for the patient. So what if we're working with the patient and we determine that no, the hospital, the ED is not the right patient placement for this patient at this time? I think I mentioned earlier the importance of documenting what resources would be needed for the patient to discharge directly from the ED or go to a different level of care. If you're a referring patient to a rehab, you can go directly to inpatient rehab. From the ED, you can go directly with home infusion. But if you don't have those resources available to you, you're stuck. So you want to make sure that you're capturing the reasons why patients cannot be safely discharged from the hospital, from the ED, and to why you need to keep them. This is really important as the case management leaders and hospital leaders try to address the reasons why. We've talked about teaching team members, but it's a constant effort. If a patient comes in from a facility, you want to understand the reasons why they came in and if the patient would be able to go back to that same facility. What services does that facility have that you can tap into? Do they have the ability to run IV fluids? Do they have the ability to provide the wound care that is necessary? What may be required is that you are teaching the ED clinical team members, this is something they can do back at the facility. They save their bed. We can discharge the patient back to the facility in a few hours. They may be coming to you for that information. So it's really important that you can maintain your network of post-acute facilities and discover ways that you can continue to gather information from those post-acute facilities, services, and agencies that's current? Do they still have the ability to provide pulmonary rehab? Do they still have the ability to provide hemodialysis? What we've noticed is that some of the available resources in these facilities are being cut or diminished or downsized, and it's really hard to keep up with what these facilities and agencies can provide on any given day. So talk with your colleagues, talk with your leaders about ways to stay connected in your immediate local zip codes and areas as to what the agencies can and cannot provide at that given week in that given month. What may be helpful is if the case management team in the ED had one cell phone that they continue to rotate amongst each team member, and facilities are expected to call in to say, I just sent Mrs. Jones to the ED. Here's our number. You can call us back. Create that expectation from your local community partners and agencies that they're expected to leave a message on the ED case management group phone to say, we're sending this person in, and here's the number to call us back, and we could talk about what the plan is. We've seen a lot of success from different hospitals that have started that network. And it's really important to continue to stay engaged with the social services representatives in the community. I know in the Boston area, we have wonderful community partners that are managing shelter services, food insecurity services. Your social work clinical partner may be able to assist you with that. If not, just stay engaged with your social service representative in terms of managing what is available to patients and how we're connecting that patient to social services once they're discharged. Many ambulatory clinics now have social workers in their clinics, so you can refer the patient for follow-up to those social service experts in ambulatory. Ideally, we would have some follow-up so the patient continues to receive information and resources about the social driver that's bringing them back to the ED. So most importantly here, I think it's really important that as you experience challenges in the ED that are preventing you from discharging a patient to right back into the community, that we continue to track that information, that we work on those systemic issues that are causing this influx of patient volume to the ED, and that we are trying to manage, and we cannot get these patients out of the ED because of those systemic challenges. So a few ED best practices, and I'm just checking my time here. I know we're getting close to questions, and I would love to hear your ideas. Just in summary, constant education of the interdisciplinary team members, not only day-to-day in your location in the ED, but presenting to the ED department routinely, clinical social work, RN case managers, social work case managers, presenting to the ED department routinely regarding what you are seeing, what the trends are, what the statistics are, where we have opportunities. I think, again, the teaching element of our role is very insightful, and continue to communicate with the ED departments. Participate in the daily huddles. Many emergency departments have huddles every 4 hours. Don't wait for the referrals. Just listen and self-consult if needed. And then, as mentioned, strong connections with local agencies and facilities. having a dedicated communication path. And this will be helpful not only in the ED, but also to the case management and clinical social work colleagues in the inpatient units, making sure that we have a strong communication path back and forth with our community agencies. And we mentioned seated in the ED with the core team and partnered with leadership. I often recommend, lean improvements or lean process improvements. And for training, again, going back to my initial statement, is that I think that the case managers, based on their lens, have the ability to solve a lot of these challenges, and how we go about solving them and using process improvement is very important. So if we have the ability to provide process improvement training to not only the ED case managers, but also inpatient case managers, I think it would be significant advancement. So different strategies focus on readmissions, focus on chronic disease clinical pathway development, focus on outpatient improvements rather than the ED. And some of you may even be asked to get involved with ED operations improvement. As mentioned before, many healthcare organizations are doing complete redesigns of their ED. Don't be hesitant to raise your hand and say, I have some ideas as to how we can improve the flow through our EDs. Encouraging care guidelines for high utilizers. University of Michigan just published information about how they designed different care plans, different care guides for patients that frequently visit the ED. And they have seen success with that. It was identified that 16% of the total cost of care was made up of less than 4% of the patients. And I think we can all recall a few patients that were high utilizers of the ED. Continue to focus on advancements in skilled home care, home infusion, hospice, ambulatory follow-up. Hospice transitions out of the ED have really been the focus, especially at Brigham and Women's Hospital in Boston. Really building that pathway for patients that come into the ED that are end of life, and how we gracefully transition these patients to either outpatient hospice or to hospice in a facility is very important. This was done after analyzing delay day data or avoidable readmission data that was collected to acknowledge that end-of-life patients were high volume coming to the ED. So they set up this ED to hospice care pathway. And I mentioned, case managers are playing a great role in the redesign efforts of ED departments. A hospital in St. Louis just did a complete ED redesign and included case managers and saw significant positive gains. So just in conclusion here, the solution for the ED boarding cannot come from a single department, but engagement of the ongoing commitment of leaders throughout the hospital, and more broadly, interdisciplinary teams that include payers, that include regulatory agencies, that include healthcare system leaders. And it's not just the ED and the capacity challenges in the ED that are the issue. This is really a systemic redesign that is required to help with this capacity concern. So encouraging everybody here to ask organizational leaders if they can get involved, to explore care continuum software that can continue to connect different EDs across the region and share information, continue to get involved with social drivers of health initiatives in your area, and continue to get involved with professional organizations that have these ongoing conversations about creative solutions and advocacy at the regulatory level. So many references here. I think you all will get the slides at a later date, but happy to answer any questions or would really like to hear about some creative ideas that we can engage in conversation for solutions.
Thank you so much, Kim. I have 3 questions. Thank you, Greg.
Sure.
If you want to put your camera on, Greg. Dr. Hirsch has the first question for Greg. For transfers, the issue of who pays for the ambulance to go from hospital to hospital comes up. Can you address that briefly?
Hi, yes, because the return leg of the ambulance is not considered medically necessary. We have a system where the MGB AMC that's sending the patient, they cover the cost of the ambulance. And when we send our repatriation letter agreement to the patient and family, there's a section of that that explains to the patient and family that we will be covering the return leg and that they will not get a bill for that.
The second question is for Kim, and this is from Krista. The SNFs are now all getting such poor ratings from CMS, so many with warnings of being cited. With these concerns of less SNFs and less qualified SNFs, has anyone's organizations opened swing beds or SNF at home programs, pros and cons?
Yeah, that's a great question, and it's a significant concern. You know, as mentioned, the rehab SNFs agencies are under intense pressure to enhance quality. They have staffing concerns. They have very chronic patients that they're trying to manage, and the continuous education for their staff on how to manage those patients. Yes, there is the star ratings in play. And we are seeing a lot of fluctuation across the market. Maybe facilities that were once 5 stars go to 2, or 2 go to 4, or it's kind of all over the place. And it's, again, really hard to keep up with. And I really feel for our post-acute providers that are trying to manage these facilities with the increasing regulations and stipulations and detail that they have to manage. But yes, you know, even in the Teams model, like we could only use, you know, inpatient stays less than 3 days if a facility had a 3+ star rating. So we're seeing a lot of movement with that. So again, it's a very complex space, and it is gravely concerning that facilities are fluctuating so much, different ownership, different results, and how we manage that as healthcare organizations. I think the last part of that question, it's just challenging. It's just challenging. I'm concerned that more facilities will close. I'm concerned that the facilities won't able to keep up financially or from a quality perspective, that they'll see repercussions from regulations. It's gravely concerning.
And the last part of that question, Kim, was, has anyone's organizations open swing beds or SNF at home programs, pros and cons? If that's what you were asking.
Right. Oh, sorry, great question. I think many organizations are considering that, different ways to manage this population of patients that need SNF level of care after an acute hospital. I think opening swing beds is an organizational decision that they need to think about in a lot of detail. And it may be right for some organizations and not right for other organizations. But it's an option, you know, it's an option for organizations to consider.
Kim or Greg, Mary has a question. Kim, do you staff your EDs 24 hours? If so, do you use both RN and social work case managers or more social work overnight?
I could take that question. I think that each organization has to make their own operational decision. In larger EDs, there's a complement of social work and RN case managers. There is also a complement of physical therapists, occupational therapists, etc. And I think it's important for organizations to match their staffing to the flow of patients that are coming to their EDs. Using different staffing models, 8-hour shifts, 10-hour shifts, 12-hour shifts. I've seen the gamut of different variety of staffing. Clinical social work is required in a lot of academic medical centers, and definitely trauma and pediatric medical centers, that we have the skill set of a clinical social worker, 24/7. It can be an on-call process, or they can be physically there in person. I think that's vitally important, especially when managing traumas and high-risk situations. The skill set of a clinical social worker not be replaced. And it's very important we have those experts in our ED. In terms of RN case management, many organizations do not utilize 24/7 overnight case management, but definitely 7 days a week. Between the hours of 10 and 2, there's only so much you can do. It's important to level patients from a utilization review standpoint. But again, managing staffing and volume of concern is the ultimate, decision maker in terms of staffing.
Thanks, Kim. Jean has a question. She is working at a facility that receives transfers from MGH ED to her ED. What is the criteria that is used to decide a patient could be better served at a nearby community hospital? They seem to run towards custodial patients.
Yeah, so there's standardized criteria. It involves the attending provider for the patient transitions role that's present in the ED, and the patient and their family. So it's a discussion amongst making sure the provider feels that the patient is getting the right service. They have capability grids that they use. They know what community hospitals have, what services, what consult services, what procedural capabilities. And first and foremost, patient consent is required because all our facilities have separate NPIs. So a transfer requires the patient consent, and you have to sign all the ED paperwork, MTELA, and all that. So it's very heavily regulated. The patients have to meet a lot of different criteria and check marks to make sure that it's safe. And it's definitely a team discussion.
Mary has another question. Thanks, Greg. How do you handle the impact of required patient choice with the diminishing numbers of facilities available? And the same with trying to move patients between acute facilities if a patient does not want to go to a community hospital from an academic medical center.
Right. We definitely respect patient choice if they do not want to go. We stop the discussion. It has to be in congruence with the patient's thoughts. In terms of patient consideration, we do have to ask for choice. That is a mandate. And so we do. Any of our inpatient areas, we offer choice and talk about different options of post-acute facilities and refer accordingly. The patient still is the ultimate decision maker regarding their next progression of care. And we do it delicately every day, just like all of you on the phone, trying to weigh best options for the patient, presenting that information to the patient, being that conduit between the insurance company as to what the options are under their health plan, and following some of the guidance that Dr. Hirsch talked about this morning, if we're at a standstill. But as you all know, it's a delicate dance. There's a lot of options. You start with plan A and end up with plan D. And it just speaks to the skill set, I think, of the case managers, having many different angles that you're looking at as to how to get to the end of a good discharge plan for the patient that's patient-centered and, in a timely way.
Another follow-up from Mary. She started an enhanced therapy program to rehab SNF patients when no post-acute resources are available. They've also opened a 40-bed transitional care unit for long-term care and have
Right.
patients who they can't place, but this occupies 40 potential acute beds. It's all give and take
Right.
to
Right.
patient
Very
care
true.
needs. Yeah.
Yeah, and what we're seeing too is because of the elongated length of stay for some of these patients in acute care hospitals and the many challenges that we all face every day um, in creating a discharge plan for the patient, many hospitals are then taking those long length of stay patients and moving them to a separate unit of the hospital with a different a complement of interdisciplinary team members. There may be more nurses aides. There may be some physical therapists available who are just trying to manage patients that are more custodial in nature. We're starting to see that at some of the larger hospitals. They are acknowledging that we are still caring for these patients in an acute care hospital that are no longer acute care, but yet how to continue to provide care to them. That's a little bit different than an acute hospital, high acuity. So that's an interesting development as well.
Greg, do you have anything to add?
Nothing to add for that.
Any other questions? An anonymous person is asking, how do you manage the skill level of the case manager with this complex process of discharging a patient, as the skill level can affect length of stay?
Yeah, oh yeah, definitely, definitely. And this could be another whole presentation, I think, in a future idea topic. But what we're seeing across the market and for nurse case managers is there many team members are coming to case management as a newly licensed nurse or brand new to the field of case management. I mean, those who have been in this space for a while, this is a significant shift from the type of education and orientation that we've had for case managers in the past. I mean, before we would, just onboard a colleague who had case management experience somewhere else, and it would be a short orientation process, and everyone went on their way. Now we're onboarding nurses who are not familiar with the detail of a case management role. And so we have to provide a more thorough, comprehensive orientation program to get them up to speed. And as many of you know, this space is so detailed, so challenging. It takes a while for new case managers to feel comfortable in this space. So that's been one challenge. And the second challenge is for those case managers who've been working in the field for a while, there's so many changes, right? Dr. Hirsch described some. Dr. Morley described some 2 weeks ago. There's so much to keep up with that we've had to completely redesign our ongoing education programs and how we're providing education, when we're providing education, and making sure it's meeting the needs of all of our team members, no matter what point they are in their career. We're investing a lot in our ongoing education for our frontline team members because that's where it's needed. And we've talked about today how we need to continue not only with our base education, but understanding what's happening in our post-acute spaces. And for each colleague on the phone today, that's going to be a little bit different depending on where you practice, but staying engaged and in tune to what's being offered in the community and also what our commercial payers are doing. We haven't really talked about that much, and that could be another whole conversation. But some of our commercial payers are adjusting, let's just say, the rules and workflows a little bit. And that's also challenging to keep up with. It's hard to find a contact number for someone who will authorize post-acute benefits for this patient with this type of plan on a Friday before before Christmas. So, there's many challenges. So how do we keep everyone in sync? How do we keep everyone in step? So, yeah, many challenges, but I think it's important that we heavily invest in our ongoing education for this subspecialty.
I can truly say that a great onboarding program makes a lot of difference. I work for a large system as well, and the onboarding is just it's a foundation for case managers that have not done this job, who are new to case management. So that type of investment goes a long way.
Yeah. But also kind of getting down the pipeline a little bit. How are we educating nurses in schools of nursing about this specialty? And in social work programs, how are we continuing to educate social workers as well? It's really important. Like navigating this space has become so nuanced. I know many of the schools, health services schools of social work and nursing in the Northeast region now have master's programs in case management, which is phenomenal. Many certification programs, professional organizations like this one. It's important that we open the door to many colleagues, even outside of nursing and social work, who want to practice in this space, to our future. We know that this is a space where we're going to need a lot of team members in the future, and just explore different ways of delivering care and providing resources to our team members. Just talking to other organizations, many use community health workers. Some are using different types of navigators with different educational backgrounds. Just being open to the exploration of what those team members can bring to a comprehensive patient discharge plan is important.
Kim, I'm curious to know if you're able to speak to, or Greg, if you're able to speak to the interdisciplinary roles of the case manager and the utilization manager in terms of shortening the length of stay, in terms of decreasing ED capacity or addressing those issues.
Sure. I can take this one, Greg. What I've noticed across different organizations is there's not one right way to do things. Each organization has a different role groups. And in some hospitals, case managers do the utilization management, the care coordination, and the discharge planning. Other organizations, utilization review is completely separate, and the case manager completes the care coordination and discharge planning. In other organizations, it's a mixed model with social work. There's many different types of roles, and there's no right way or one way to do things. I think what is important, though, is that each organization has a dedicated team member, no matter what their role, handling the utilization review management element. And Dr. Hirsch reviewed it this morning. It is the revenue cycle. It is how these organizations get paid for the hard work that we all contribute to. Every organization has to have a dedicated process to making sure the leveling is right, that the notices are given to the patient at the appropriate time, and that we're managing that revenue cycle encounter in a timely and compliant way. So no matter what the role type or the name, a dedicated colleague needs to complete that function. you know, whether it's in congruence with the case management workflow or not, or if you call it something different, it is just absolutely vital.
Mary has a comment. They did not relicense the beds, so they're still acute. Most transitional care unit patients have received a hint. Some have qualified for days awaiting placement. Multiples have no payment source any longer, but there isn't a safe discharge plan, so that limits movement.
So many nuances. Yeah. And
Yeah.
swing beds, you know, are complicated to manage for those organizations that have them.
Kim, have you seen the role of, going back to and case management, have you seen like a huddle between, not between, but a huddle that included to say, look, this is what this length of stay is for this condition, or for this, for the documentation that we've, reviewed, and this is your patient's length of stay. How can we move? Is there, do you have any experience with that type of interaction, or huddle type of?
Yeah, that's a good question. I mean, if the utilization management element of the role is separate from the care coordination and discharge planning role in your organization, it is very important that there's continuous communication between both for many reasons. One is that the case manager who's managing the case or coordinating the case and preparing for discharge needs to understand how the patient was leveled. That is going to determine many of their options and different pathways for discharge. For example, the patient was leveled as observation. The case manager then knows that the SNF stay will not be covered if it's a Medicare patient with an observation status. So conversations need to begin about private pay or about other arrangements, etc. So if the patient was leveled as inpatient, it's a different story, and the case manager needs to know that. If the patient was completely denied the inpatient stay, and we need to have some tough conversations, that needs to be known as well. Between the role and the care coordination role, you need to understand who's delivering the paperwork to the patient, the MOONs, the IMs, the ABNs, any non-coverage letters. That you need to have an understanding or a dedicated workflow to know who is handling that process as they're interacting with the patient. Also, it's important for the care coordination case manager to understand the nuances of the patient's insurance plan. And usually the colleague it is well nuanced in that, but the care coordinating nurse case manager really needs to understand that as well. And that may be a relay of information, or that the care coordination RN is very much in tune to it, but it does help define how the discharge plan will be laid out. For example, if the patient has a PACE plan in the state of Massachusetts, they have numerous discharge options available to them, and an ambulatory network that they could hand off to, and different resources available to the patient, which is different from other health insurance plans that don't have that network of post-acute options. So either way the role is designed, it's really important for the care coordination nurse case manager, the one who's doing the discharge planning, to stay significantly in tune to the utilization management of how those plans operate, and who to connect with regarding the plan's benefit structure.
Teresa has also made a good point. She's a director of care coordination, and she has daily huddles with her CM, and CDI nurses to discuss this, and if max DRG has been hit.
That's wonderful. And that's a very advanced practice. Kudos to you, Teresa. You know, how we instill CDI colleagues into our work is very important. There's many software systems out there. There's many EMRs that have information included on patient lists as to what the preliminary admitting diagnosis may be, or what the anticipated length of stay is based on chief complaint or preliminary diagnosis. That's wonderful, helpful information to have. If your healthcare organization, if your systems, if your CDI team members have a way of integrating that knowledge into the EMR, that's phenomenal, so that the case managers can see that. I anticipate going forward that is going to be more and more essential. For example, the Teams model that Dr. Hirsch talked about this morning, those are based on disease conditions and or surgical procedures that have incurred. So how does the frontline case manager or the UM manager or the clinical social worker or the physician know whether or not the patient is going to be within that Teams model based on the CPT code or the OR procedure that was performed, or the specific admitting diagnosis that was assigned? That's absolutely essential for us to know to determine if the patient is eligible for certain Teams model benefits upon discharge. So again, getting the information to the clinical team, the interdisciplinary team that's involved with the patient at the time, is absolutely essential. So Teresa, if you have some words of wisdom for us all as to how your CDI team members get that information back to the frontline team members in a timely way, that'll be really beneficial.
There's two comments that every Medicare Advantage plan has a team of CMs, and they have seasoned CMs and UR professionals. Interaction with them can be useful.
Very, very. And a really strong component of working along the continuum of care and actually inviting the payer case managers, the payer social workers into the conversation as to how we discharge these patients, and to have a very integrated model. In a perfect world, we would have our inpatient interdisciplinary team members being able to hand the baton to the next level of care, to the next colleague or team member along the progression of or continuum of care. So ideally, you know, for very complex patients, those Medicare Advantage case managers informing us, the hospital team, to say, we know this patient really well. This is what has worked best with the patient. Just please tell me when the discharge date is, and one of our case management team members will follow up, you know, within 24 hours. We can set up the primary care appointment, etc. There's a team approach that I think we can lay out that is actually inclusive of the case management social work team members in the insurance plans.
Thank you so much, Kim and Greg. I want to echo Pat's statement for reinforcing the importance of case management's role and voice within the organization and other forums. Great presentation, great discussion and questions. Thank you so much to you both.